Good morning, friends. Now, after the overview of lung cancer, our next topic of discussion is molecular oncology of lung cancer. Uh, Believe me that this is such an important topic that considering the fact that most of the lung cancer are present in the locally advanced stage of inoperability, as well as such a heterogeneous disease that the chemotherapy is not merely a very sufficient for this kind of a cancer. Understanding the immunotherapy, targeted therapy is a backbone now for lung cancer management. So let us start the molecular oncology of lung cancer. Slides are very limited. So line by line is you should be focused, which I am addressing you, stressing you, so you can better pick up the management of lung cancer by targeted therapies. So, lung cancer, considering the leading cause of a cancer-related death, and histologically as well as molecularly, such a highly heterogeneous disease that prompts us to investigate about the molecular markers of this disease for a better treatment, prognosis, and prediction. So, lung cancer classified according to the previous WHO classification based on the biopsy only or a surgical specimen, and mainly divided into non-small cell lung carcinoma and small cell lung carcinoma. And a further non-small cell lung carcinoma divided into the squamous, adeno, and large cell carcinoma. And a squamous cell carcinoma further ramified into three categories like epidermoid variety, spindle variety, and mesothelioma types. Now you consider like adenocarcinoma is divided into three categories like acinar variety, papillary, bronchoalveolar categories on the histopathological basis. And small cell lung carcinoma divided into the oat cell, intermediate, and mixed variety. So all in all, if you see the lung cancer is divided into non-small cell and small cell, and 85% lung cancers are non-small cell variety, and only 15% are small cell cancer variety. That is old previous data and is based on the histological studies that we have already described you in the previous lecture, like the adenocarcinoma usually peripheral in origin, squamous cell carcinoma is usually associated central lesion associated with smoking, large cell carcinoma again is a peripheral in origin, and a small cell carcinoma are central in origin and with massive lymphadenopathy and along with the paraneoplastic syndrome. And few of the varieties are the neuroendocrine, that is carcinoid variety. It's merely 5% of all lung cancer. So in the era of immunohistochemistry, when we classify the lung cancer in the various molecular subtypes, it helps us to take a decision making for a specific target therapy for lung cancer. Like ISC study, we look for adenocarcinoma first, confirm whether the adenosquamous, neuroendocrine, or a NUT gene positive lung carcinoma. And then after, we further see for molecular markers like ALK positive, EGFR, ROS1, PDL1 subtypes of lung cancer. So, for adenocarcinoma, once immunohistochemistry shows the adenocarcinoma, then you must look for TTF1, thyroid transcription factor 1 is basically a nuclear enzyme along with the napsin A. If both are present, then you consider this type variety as a adenocarcinoma on an immunohistochemistry basis. But if we get P40 positive, CK56 positive, TP63 positive, this carcinoma and this variety of carcinoma is diagnosed as a squamous cell variety. Actually, this modification has made decrease the proportion of large cell carcinoma, which earlier used to wrongly diagnose the large cell carcinoma, so that the data of a large cell lung carcinoma percentage is markedly decreased because of advent of immunohistochemistry. So there are neuroendocrine varieties of a lung cancer, and their neuroendocrine varieties are small cell lung cancer, large cell neuroendocrine carcinoma, and carcinoid variety. In all three variety, two variety of small cell carcinoma and large cell neuroendocrine carcinoma is an absolutely lethal disease, highly aggressive and have a poor outcome. In contrast to carcinoid variety that have an indolent course of a disease. Further, we look for a Notch1 HES1 signaling pathway. A neuroendocrine tumor formation happens by inactivating the INSM1 ACL1 transcription factor. Actually, the process starts, the Notch1 activates the HE1, which inactivates the IMS1 and ASC1 marker. So ISM1 promotes the expression of neuroendocrine marker like chromogranin, synaptophysin. These are the markers for neuroendocrine differentiation by which we diagnose the neuroendocrine tumor. And another CD56 and NCAM marker by activating the transcription factor ACL1 and BRN2. So finally, we could understand the ISM1 appears to be the key factor for neuroendocrine differentiation of lung cancer. Henceforth, ISM1 may serve as a single most important marker for neuroendocrine lung cancer differentiation. The ALK, ROS1, EGFR genetic markers, these various genetic alteration in tyrosine kinase have been identified among the adenocarcinoma lung. Like ALK stand for enough plastic lymphokinase positive adenocarcinoma, reported to be comprises of 4 to 5% of all adenocarcinoma. So in case of ALK positive adenocarcinoma, if you're putting a patient on the geftinib or elrotinib, certainly you're not going to get any response in the patient. So because the ALK positive tumor should be treated with a crizotinib. So these are the actually advantage of immunohistochemistry. And the more positive thing is that we get in most of the cases, FNAC report, the core needle biopsy of a lung cancer is highly recommended for IAC study. So henceforth, the ALK inhibitors like crizotinib, lorlatinib targeted drugs are very helpful. And in a ROS1, that is a proto-oncogene 1, positive adenocarcinoma is merely 1 to 2%. And adenocarcinoma should be considered for ROS1 inhibitor, those the ROS1 is positive. The EGFR mutants are the most common mutation found in adenocarcinoma or lung cancer. EGFR mutant adenocarcinoma lung shows TTF1. The EGFR mutations are divided into 4 major categories: the point mutation exon 18 chromosomes, deletion of exon 19 chromosomes, insertion in exon 20, and point mutation in exon 21. These are the mutation takes place in the epidermal growth factor receptor positive adenocarcinoma. But out of 4, the 2 mutations are present in 90% case of epidermal growth factor receptor mutation, like exon 19 deletion and a point mutation in exon 21 chromosome in a 90% cases. So, a web type of lung cancer variety shows superior prolonged clinical response with tyrosine kinase inhibitors like gefitinib, vellotinib drugs. So, this is a chart which shows you the correlation between the epidermal growth factor receptor KRAS mutation. If you see if EGFR negative, KRAS negative, but ALK positive, consider the patient for ALK inhibitors. And if ALK negative, they consider the tumor for a combination chemotherapy. And if EGFR positive and KRAS negative, consider the EGR tyrosine kinase inhibitor. Another marker very important, PDL1, that stands for CD274. This PDL1 that stands for program death ligand 1, which is expressed on the T cell that promotes the immunosuppressant action by binding to the PD1 on the surface of a tumor cells, actually binding to PD1 on the cytotoxic cells. Thus, anti-PD1 antibodies allowing immune-mediated attack against the tumor cells. So henceforth, using these antibodies for treatment of non-small cell carcinoma showing a great promise, particularly if a non-small cell lung cancer with 50% or more positive for PDL1 were associated with a higher response rate. But now it has been seen even a 1% positive of PDL1 do response with the anti-PDL1 targeted therapy in non-small cell lung carcinoma. Drug used are as a anti-PDL1, the pembrolizumab, nivolumab, and most recently FDA approved in 2017 a drug is a avelumab. So another variety of lung cancer, the mesothelioma, is rare but a fatal tumor and is divided into the epidermoid, sarcomoid, and biphasic. But the epidermoid variety of mesothelial carcinoma is among the mesothelial carcinoma of lung is approximately 60 to 80%. What are the genetic markers for this? BAP1 gene on immunohistochemistry study and deletion of P16 is a potential indicator of malignant mesothelioma of lung cancer. Another protein, that's the nuclear protein of a testis nut carcinoma. This type of lung carcinoma recently added in WHO classification of lung cancer, which used to misdiagnose more often as a different type of lung cancer. Mostly basiloid type of squamous cell carcinoma or a small cell carcinoma, lymphoma or germ cell tumor. Nut carcinoma is defined by genetic rearrangement between the nut gene and a chromosome 15q fused with the bromodomain family member BRD3 chromosomes in 19p, comprising of 70% of a nut carcinoma, and BRD4 on a chromosome 9q, comprising 6% of a nut carcinoma. All in all, you must know that a nut carcinoma is a highly aggressive variety of a lung cancer, having a poor prognosis, very aggressive behavior, dismal outcome. Median survival is only 2.2 months. Because this variety do not respond to the chemotherapy, do not respond to the radiotherapy, but somehow molecular targeted therapy is the last ray of hope against the bromodomain positive nut carcinoma. In conclusion, the current WHO classification, ISC study is indispensable to the determination of lung cancer subtypes. Furthermore, ISC study have been approved by the US FDA as a complementary for diagnostic assay for molecular targeted therapies. Moreover, an increasing number of targeted therapies will require ISC study evaluation in order to determine the eligibility of patient for certain targeted treatments. The relevant biomarker in lung cancer collectively as a part of current era for precision medicine, immunohistochemistry study have a great promise for improving the diagnosis and treatment of a lung cancer. The crunch point, you must note down that the non-small cell lung carcinoma, those who are PD-L1 positive after giving a platinum-based chemotherapy, adding anti-PD-L1, atezolizumab increased the overall survival rate. And the recent study says even PD-L1 only 1% positive, you add the atezolizumab targeted therapy in these group of patients. They do respond well. And in a small cell carcinoma, after giving a cisplatin and etoposide-based chemotherapy, or in combination with durvalumab, prove increased overall survival. So all the information is being collected through this Principles and Practice of Molecular Oncology and Radiobiology book, my own book, and this is the end of, this is the last slide. So you can go through one by one slides and study very well, because the lung carcinoma is the topmost cancer in India, is being rated. So, and the most of them is presented in the locally advanced stage. So the molecular oncology you cannot skip in order to treat the lung cancer. Thank you very much.